Assalamu alaikum and good morning. Continuing with our lectures on thyroid disorders. This is fourth of the series of this lecture on thyroid disease, and today our focus would be on hypothyroidism. Now, this is our today's case scenario. A 32-year-old female executive in a multinational organization. She started having low mood, lethargy, weakness. She lacked initiative and drive, and she had been receiving excellent performance awards for 3 consecutive years, but has not been considered for regular annual promotion this year. She got frustrated over this neglect and started using antidepressants on advice of her general practitioner. She was repeatedly found sleeping in her office, and the pile of files in need of her comments swelled upon her desk. Her boss noticed this, and then he arranged a psychiatrist consultation, and some laboratory screening was done, and a medical consultation was advised. This lady was having a depressed mood, was slow to respond to questions, and reports being lethargic, sleepy most of the time, or somnolent, and feels that winters are becoming increasingly cold over the past 3 years. Her appetite has reduced, she feels constipated, and her periods have been unusually heavy for the past 9 months. Her hemoglobin was low, so she started taking iron supplements on advice of her GP. She also complained of pain and numbness in lateral half of her hands, particularly when she rises up from her desk, placing them on table for support. On examination, we had a lady who was having cold, rough and coarse skin. She had a slightly hoarse and croaky voice. A mild diffuse goiter was noted. Her pulse was 56 beats per minute and dropping up to around 40 beats per minute sometimes. Her blood pressure was 150/95. She had non-pitting edema over her ankles. There was hypoesthesia over the lateral 3 fingers of both hands, and delayed relaxation of the ankle jerks was also noted. These were the features which were noted on examination. She already had some lab reports with her, which showed that her hemoglobin was 11.5 gram per deciliter. Her MCV was 104. Mean corpuscular volume was 104, meaning by she had a macrocytic type of RBCs. Her CPK was markedly elevated, 550 nanogram per liter, and serum cholesterol was 230, and there was slightly raised ALT. But the most striking finding was a markedly elevated thyroid stimulating hormone, or TSH, which was 100 nanogram per deciliters. Now, all these features of her history, her physical examination, the lab data available suggest a diagnosis. And this was her ECG, which was showing marked sinus bradycardia with a very low voltage ECG, along with T-wave inversion, which are again very classic of the condition which we are about to discuss. An X-ray did show marked cardiomegaly, which was consistent with either pericardial effusion or dilated cardiomyopathy. So what's the diagnosis? As I said, that when you look up it in whole or in totality, the lady who is in her say 30s and has been complaining of weakness and lethargy and somnolence and cold intolerance and constipation, physical features which are of coarse skin, some hoarse voice, delayed relaxation of jerks, signs of median nerve compression in the form of carpal tunnel syndrome, and some hypertension being noted, and lab investigations of note were macrocytic anemia, along with an elevated TSH and a low voltage ECG. So this all points towards hypothyroidism. Now, what is hypothyroidism? This is one of the most common endocrine diseases. Yet it is grossly underdiagnosed, and many of the patients, they remain subclinical, or they do have biochemical evidence of hypothyroidism, but clinical manifestations are subtle or very less, so they remain undiagnosed for quite some time. Again, female to male ratio is quite high, 8 times more common in women as compared to the men. 90% of the patients have primary hypothyroidism, and by that we mean that when there is a defect in the thyroid or synthesis of the thyroid hormone by the thyroid, it is called as primary hypothyroidism. When there is a defect in the pituitary, which is unable to produce thyroid stimulating hormone, and so there is say lack of stimulation of the thyroid gland by the pituitary. This is called secondary hypothyroidism, and then this TSH in itself is under influence of hypothalamus through the thyrotrophin releasing hormone. And if it is because of the hypothalamic disorder, then we call it as a tertiary hypothyroidism. The major manifestations, as it's more common in women, they are in the form of menstrual irregularities, miscarriages, growth retardation. They may complain of vague pain. Sometimes anemia is the only manifestation. They remain or complain of constipation, lethargy or slowness, cold intolerance, or say they feel cold weather being not very pleasant for them. They do get weight gain, and as in our patient, there was some hypertrophy or the tissues around the say carpal tunnel, and median nerve compression presenting in the form of carpal tunnel syndrome can be a frequent complaint. Now, as far as the frequency of or incidence of hypothyroidism, that how common it is, it's quite common. 5% of the general populations are subclinical hypothyroid. So every say 20th person around you, adult population, may be having hypothyroidism, which is not yet diagnosed. When you go on to the rather slightly older age, in women, particularly those who are more than 65 years of age, 15% of those women, they are having hypothyroidism. Detecting subclinical hypothyroidism in pregnancy is very essential, because this TSH and free T4 should be routinely checked in pregnant women, because they affect the well-being of the fetus, particularly in third trimester when the organogenesis is taking place. In fact, all the person aged above 60 years should be checked for hypothyroidism or subclinical hypothyroidism through screening of TSH. Which population or which people are likely to have hypothyroidism? It can be seen in every age group, but more frequent in elderly, particularly 60-65 year plus, and particularly in women. 1 in every 10% have a thyroid disorder, and 1 in 5,000 infant has hypothyroid disorders, which should be diagnosed at birth, because lack of thyroid hormone would lead on to not only growth retardation physically, but mental retardation as well. In most part of the world, it is the iodine deficiency which is the cause of primary hypothyroidism. But in those areas where iodine deficiency is not very common, it is the autoimmune disease like Hashimoto thyroiditis which is the common cause of hypothyroidism. So we have two types of regions with hypothyroidism. One, those regions where there is iodine deficiency, we do fall into that region as well, or are people living in the mountainous areas where their salt is deficient or diet is deficient in iodine, they suffer from an iodine deficiency type of goiter. But rest of the world, it is autoimmune disorder of thyroid which leads on to thyroid cell destruction and results in say hypothyroidism, despite that the diet is sufficient in iodine. This is the list of causes. You may have hypothyroidism presenting with goiter, and without goiter, meaning by that there may be a thyroid enlargement associated with hypothyroidism, and sometimes it may be with the normal size or of the thyroid, still patient may be hypothyroid. So Hashimoto, iodine deficiency, drug-induced goiter like drugs, those who are using drugs like lithium, amiodarone, antituberculous like paraamino-salicylic acids, ethionamide, and rifampicin, all again antithyroid drugs, they can have relative iodine deficiency resulting in goiter and then hypothyroidism. There are some diets which are called goitrogens, or they can lead on to goiter formation. Again, mainly these diets are the one which probably either stop the absorption of the iodine from the gut, or they interfere with the uptake of the iodine by the gland. So this can be Riddle's thyroiditis is another type of thyroiditis where thyroid gland is not enlarged, but it undergoes some autodestruction and leads on to hypothyroidism. Without goiter or without enlargement of thyroid gland, the cause is again sometime early Hashimoto's thyroiditis may not have the goitrous enlargement of the thyroid and still may be presenting as hypothyroidism. Those who have undergone radioiodine ablation for maybe goiter or for any other thyroid disorders or nodule may later on develop hypothyroidism. Those who have undergone thyroidectomy for either benign or malignant condition or for cosmetic reason for goiter, they can develop hypothyroidism. Sometimes it can be congenitally present or because of the lack of development of the thyroid gland since during say fetal development period. And then not to forget, as we already talked about, secondary hypothyroidism, that if there is pituitary necrosis, particularly that like the example is Sheehan syndrome, postpartum pituitary necrosis as a result of postpartum hemorrhage, and this necrosis would lead on to say absence or decrease in production of thyroid stimulating hormone, and this then will result in secondary hypothyroidism. Some of the infiltrative disorders like amyloid, sarcoid, hemochromatosis, or connective tissue disorders like scleroderma may all be associated with development of hypothyroidism. We already talked about that if the thyroid dysfunction, primary thyroid gland is the reason for dysfunction or lack of production of thyroxine or lack of concentration of iodine uptake by the gland, it is called as primary hypothyroidism. But when it is because of lack of production of TSH from the pituitary, then it is called as secondary, or it may be part of panhypopituitarism. And when it is because of the lack of the hypothalamic thyrotrophic releasing hormone or TSH releasing hormone set deficiency, then it would be called as tertiary. Some other causes of hypothyroidism do include postpartum hypothyroidism and drug-induced hypothyroidism. The most common presentations of hypothyroidism, the symptoms usually include dry and coarse skin, which is seen in 76% of the people, cold intolerance in around 64% of the people, some rounding of the faces or puffiness of the face, or this can be seen in 60% of the patient. 54% of the patient paradoxically complain of increased sweating, and around half of the patients may complain of weight gain. Paresthesias, like as we described in the form of carpal tunnel syndrome or numbness of the hands and feet, can be seen in 52% of the patients. Constipation is again a very common feature because of the decreased motility of the gut, again seen in 50% of patients, and sometimes there may be non-specific aches and pains as one of the presenting complaints. When you examine them, in relatively advanced stage of hypothyroidism, the delayed relaxation of the ankle jerk is probably the most common physical finding, which is seen in almost two-thirds of the patients or 77% of the patients. Slow heart rate or slow pulse, bradycardia, again seen in 58% patient. Somnolence or increased sleepiness or drowsiness can be seen. Uh, this can be one of the reasons of diastolic hypertension, and sometimes a cause of resistant hypertension. Majority of these patients have a depressed mood. They may have a macrocytic anemia, and menorrhagia again can be a very common feature, and infertility again may be the presenting complaint in many of the women presenting with hypothyroidism. The uncommon features of hypothyroidism may include someone may be noticing hoarseness of the voice because of the some swelling of the say vocal cords as a result of myxomatous material being deposited there. Same may be the reason for deafness or being hard of hear. Ascites is rather uncommon presentation but can be there, but more common are pericardial and pleural effusions. Similarly, we did talk about carpal syndrome as a presenting complaint. Some of them may present with erectile dysfunction or impotence. Galactorrhea and amenorrhea again are one of the features, and the reason being that when you have hypothyroidism, there is an elevation of thyroid stimulating hormone compensatory elevation, and this TSH is a stimulant for prolactin, and all those who have primary hypothyroidism would have an elevated TSH, and this elevated TSH would be a reason for increased prolactin from the pituitary, and this prolactin is the reason for galactorrhea, and prolactin may be the reason for amenorrhea as well. In advanced stages, they may present with cardiac failure, and not to forget that many of them they go on to from depression to psychosis to frank say myxedema madness. These are various physical features which we can observe in these patients. Right, some of them may have gutters enlargement, and sometimes they may not have any enlargement of the thyroid. And this is how serially these features progress. Now, hypothyroidism mimics or can be, say, presenting with or has to be differentiated from certain other disorders. The most important is the simple depressive illness. So there is hardly any, sometimes say it will be difficult for physician to differentiate with that whether patient is suffering from major depressive illness or hypothyroidism is the underlying cause for that depression. Forgetfulness again or dementia can be confused. Alzheimer's dementia or other vascular dementias may have say quite a similarity with patients with hypothyroidism. Because of their overall slowness and lethargy and all that, and add to it depression and add to it other features, sometimes Parkinsonism may be confused with hypothyroidism or may be misdiagnosed. So this has to be looked into and has to be ruled out. And sometimes the proximal myopathies, where you have difficulty in sitting, standing from sitting position, or holding objects above your head, they may be primarily because of myopathies, but myopathy can also be a presenting complaint in hypothyroidism. So these are the 3 or 4 conditions which must be say considered as a differential diagnosis. Initial test for diagnosis of thyroid dysfunction, the primary test has to be thyroid stimulating hormone. It would decide that if thyroid stimulating hormone is TSH is elevated, the cause is in the thyroid, and if TSH is normal, we have to look for some receptor defect, and if TSH is elevated, again we have to look for receptor defect, and if TSH is absent, then we have to look for the cause in the pituitary or hypothalamus. And then of course, once you have say made an initial screening through thyroid stimulating hormone testing, you then check for free T4 or thyroxine. The initial diagnosis, the TSH usually is normal value is between 3.5 to 5, uh, 5.5 nanogram, and the normal usual primary hypothyroidism, you would have a raised TSH, a low free T4 and low free T3, total T4. Right. So the in primary hypothyroidism, you would have a combination of elevated TSH, low free T4 and low free T3. Ultrasound of the thyroid is not of any much value in patient diagnosis of hypothyroidism. It may be so in patients with suspected thyroid nodule or non-functional thyroid areas, right? Again, the thyroid scan again does not have much value. Again, we have been showing this scintigraphic images where the thyroid gland, if it is increased uptake universally, then it points towards possible Graves' disease. If it is decreased uptake in one area, we think of a cold non-functional nodule or a malignant nodule, and if it is increased uptake, we think of a say functional or toxic thyroid nodule. But in primary hypothyroidism, there may be overall decreased uptake which may not be of much value in making the diagnosis. The more important thing would be checking for the anti-thyroid antibodies, because as you said, the main causes are either iodine deficiency or autoimmunity. And autoimmunity, again, Hashimoto is the one example, but there can be thyroid TP or uh, peroxidase antibodies, and these antibodies would be maybe diagnostic of an immune or autoimmune type of a hypothyroidism. The other investigations, there may be some elevation of CPK because there is a proximal myopathy associated with some myositis associated with it. Liver enzymes like AST and LDH may be raised. They may have hypercholesterolemia and hypertriglyceridemia along with it. Most of the patient may have a normocytic, normochromic, or macrocytic anemia. There will be increased serum prolactin, we already mentioned about that, and some of these patients may have a delusional hyponatremia, which can be again another feature of hypothyroidism, which may be supportive of diagnosis. ECG findings in hypothyroidism are important. The most universal finding is sinus bradycardia or very slow heart rate. The overall voltage of QRS complexes is low. It hardly crosses 5 millimeter or half MV. There may be some prolongation of PR interval suggesting first degree AV block. These may develop rather advanced blocks like left or right bundle branch blocks. Flattening or inversion of T wave is very commonly seen. Sometimes you may also notice some premature ventricular contractions, and rarely they may present with sustained or non-sustained attacks of ventricular tachycardia, and overall QT is prolonged. So there can be a host of abnormalities in ECG which can be suggestive or sometimes even diagnostic of hypothyroidism. Whenever you have an elevated TSH, you think of following causes. As top of the list would be primary hypothyroidism. Sometime recovering from non-thyroid illness, intercurrent illness can be a reason. Pituitary adenoma, again producing TSH, can be one reason. Primary adrenal insufficiency, again sometimes may be associated with elevated TSH. Patient may be resistant to T4 resistance because the feedback for the release of thyroid stimulating hormone in the pituitary is to the T4. So if T4 is elevated but it does not say effect on the T4 receptors in the pituitary or hypothalamus, the inhibitory effect of thyroxine on the TSH is gone, and the patient may continue to have an elevated TSH. And again, TSH, the resistance at the receptor level, at the thyroid level can be. So anti-TSH receptor antibodies sometimes may have to be checked in patients who present with hypothyroidism despite an elevated TSH. Free T4, if is low and TSH is low, then it usually means that the patient has secondary hypothyroidism or central hypothyroidism, and imaging is indicated to distinguish hypothalamic from the pituitary disease. You may have to require MRI of the pituitary or hypothalamic areas, and we have to evaluate for secondary adrenal insufficiency, because in addition to low TSH, there may be deficiency of ACTH along with that, or it may be part of pan-hypopituitarism. When we start treatment of hypothyroid patients, our goals are that there should be improvement in symptoms of somnolence, lethargy, weakness, and constipation, cold intolerance. A secondary objective is that the patient should have a normalization of his TSH. So if it is elevated, it should come down to normal, so that the further stimulation by the TSH is not there. If this was associated with some, say, hypertrophy of the gland because of a persistently elevated stimulation by the TSH because of central release, then there would be a goiter formation. This goiter should be reduced. And we also avoid over supplementation, because if you have an increased overdosage of thyroxine, in particular in elderly patient, you may induce atrial fibrillation. In those who have an occult coronary artery disease, and they do have say atherosclerotic coronary artery disease, but because of persistent bradycardia due to hypothyroidism, they are not symptomatic. But once you replace the thyroxine and their heart rate goes up, they become relatively ischemic, and then they may start precipitation of their angina, merely because of elevation of this. Okay. Similarly, hyperreplacement may lead on to risk of bone loss. So this is the algorithm for the management of hypothyroidism. So when you suspect hypothyroidism, the first thing is that you measure thyroid stimulating hormone. If TSH is normal and patient is symptomatic, and you consider that patient is maybe having pituitary cause of hypothyroidism, then if you suspect that, then first you measure free T4, and if it is normal, you need no tests. But if you consider you are not considering no test will be required. But if free T4 is low, then you have to evaluate for the pituitary causes. You may have to think of pituitary, you may have to think of sick euthyroid state, or you may have to look for possible drug effects responsible for low free T4. On the other hand, if you measure the TSH and TSH found to be elevated, then we have to measure free T4. If T4 is normal, then your patient is possibly having subclinical hypothyroid, that he is producing less free T4, but this is being compensated by the increased TSH and increased stimulation of the by the thyroid, pituitary. Now, if this is the condition, you check for tissue peroxidase antibodies. If they are positive, you would require T4 replacement, and if they are negative, you possibly go for annual follow-up, and if they turn out to be having positive, then you start replacing either T4 or think of treatment. But if you measure T4 and it is low, then the diagnosis of primary hypothyroidism is established. So if it is with positive antibodies, it is Hashimoto's, and This would require T4 replacement. If it is antibodies negative, again it confirms hypothyroidism, may not of autoimmune type, and this would require replacement. When you start this treatment, you probably have to, as we already discussed, that you have to be careful, particularly in the elderly patient who may have occult coronary artery disease, and replacing thyroxine may lead on to precipitation of their angina, or their symptoms of ischemic heart disease may worsen. So you usually have to be very careful, and you have to repeatedly examine them, ask them for any symptomatic angina, and you may have to go for some further investigation test in them. Similarly, increased thyroxine may lead on to a high bone turnover and may lead on to osteopenia. The treatment of hypothyroidism is contraindicated in setting of if you find someone in the setting of acute MI and he's turned out to be hypothyroid as well, you delay the treatment till this acute MI setting is over. So you don't start thyroxine during an acute MI. You don't use this as part of treatment. Obviously, many quack or many of the physicians, they do use thyroxine as an agent for weight loss or treatment of obesity, which should not be done. And similarly, it should not be replaced immediately there and then in patients who have uncontrolled hypertension. The goal of our treatment is that the patient TSH should become less than 5.5 or within the normal range of the the test being done. Treatment is very simple. All you have to do is once daily dosing of levothyroxine sodium. The dose is 1.6 microgram per up to 1.8, and the normal usually requirement is 50 to 150 or maybe 200 microgram of day, and the dose has to be titrated. It is not that you start the full dose from the beginning. You start with the low dose and gradually increase the dose. You monitor this response through this checking their TSH levels every 6 to 8 weeks initially, and after once this whenever you change the dose, you probably have to check it for the response, and then it may be done every 3 to 6 months. The dose of levothyroxine, of course, depends upon the degree of hypothyroidism, on the age of the patient, general health of the patient. So these are the various parameters which you have to consider when you are replacing thyroxine. Usual daily replacement, as I said, is around 1.6 microgram per kg body weight, or for a 70 kg person it would be around 100 to 150. Always start with a low dose. Do not start with the full dose replacement from the very beginning, because the dose required may has to be titrated. If no residual thyroid function is there, or with total, say, lack of thyroxine production by the thyroid, the usual dose is 1.5 microgram per kg. In patients who are under 60 and who do not have any cardiac disease, you can start with a dose of 50 to 100 microgram per day, and dose adjusted according to the TSH levels. But in elderly, and especially as we already mentioned, those who have coronary artery disease, the starting dose should be much less. It may be as low as 12.5 to 25 microgram per day. They should be observed for any abrupt change in their heart rate. They should be observed for any ECG changes suggestive of ischemic heart disease. They should be repeatedly questioned about any symptoms of angina, and then the increment of dose should be done maybe every 1 to 2 weeks. After every 1 to 2 weeks, you increase it by around 12.5 to 25 microgram till they have uh, normalize their TSH and they are not symptomatic of any angina or of any cardiac symptoms. Again, stressing upon the same fact that in elderly start with the low dose. The dose adjustment would depend upon severity and duration of hypothyroidism, and you would increase the dose depending upon the TSH level. It may be weight based, that zero point 0.5 microgram per kg per day and up to 3 microgram per day you can go up. Someone with repeated diarrhea or malabsorption may have to be started on a higher dose. There are some drugs which may lead on to, say, lesser absorption of the thyroxine, or there is a first pass metabolism. That is why this is recommended uh, early morning empty stomach recommendation for this ingestion of thyroxine. In pregnancy there is always an increased demand, so you might have to increase the thyroxine dose by 25 to 50 microgram, and it can be safely given in lactating mothers. And already we said that in cardiac disease you may start with a low dose or maybe an alternate day regime for the management. These patients who are started on thyroxine should be followed up with the serial thyroid stimulating hormone levels being checked, maybe every 6 to 8 weeks initially, and then maybe uh, mm, every 3 to 6 months. The target TSH level should be between 1 to 2 microunit per liter, and once stable TSH level is achieved after repeated measurements or estimations, then you can go on to once a year follow up and checking of their TSH levels. You should obtain a free T4, TSH, LFT, CBCs before initiation of therapy. Repeat free T4 or TSH after 4 to 6 weeks of therapy, or when you do a dose adjustment. And once euthyroid state is obtained, thyroid function test should be done every 3 to 6 months and then maybe every year. Pregnancy poses a special problem. During pregnancy, thyroxine requirement would increase, and even with mild thyroxine deficiency, there are chances of low IQ and developmental delay of the child. So it should be very carefully uh, titrated, and the patient should be maintained in a euthyroid stage with the optimal delivery or intake of thyroxine as per their TSH levels. This thyroid hormone again has two forms. One is free form, and then is the this is bound to globulin form. So in pregnancy, this estrogen is increased. This increase in estrogen also leads on to increase in thyroid binding globulin, and this, of course, then would lead on to increase in total T4 and T3, but the available free T3 T4 would still be low. So however, free T4 remains normal. So in pregnancy, when you are monitoring their thyroid function, you use free T4 rather than a total T4 as a indicator for response to treatment. The during pregnancy, again the goal is to normalize TSH. The dose should be adjusted every 4 weeks, and should check TSH levels in every trimester in patients with hypothyroidism. A word about myxedema. Myxedema is a state of rather advanced hypothyroidism where there is, apart from the features mentioned, there would be a deposition of myxomatous material under the subcutaneous tissues, in the subcutaneous tissues, and around face and neck and all areas. So it usually, the second thing is myxedema coma. It usually occurs in previously undiagnosed hypothyroids or those who are inadequately treated, and elderly patients are more susceptible. And myxedema coma is a sort of a medical emergency. What precipitates it, that if someone is hypothyroid and is on inadequately replaced with the thyroxine dosage, or during infection or sepsis the requirement of thyroxine is increased, then they go into state of a mixed edema coma. Drugs like sedatives, antidepressant, and anesthetics can precipitate cardiac failure, or MI can precipitate it. Uh, Respiratory infections like pneumonias can precipitate. Sometimes there may be a CVA or GI bleed or hypoglycemia, or sometimes hyponatremia and hypoxia, hypercapnia can be the precipitating factors for mixed edema coma. These patients usually present with extreme hypothermia, temperature as low as 96 or 95 degree Fahrenheit. They are comatose. Sometimes some of them may have frank seizures or fits, and they would have other features of hypothyroidism. These patients who present mixed edema coma are usually elderly patients. They would be marked bradycardia, marked hyponatremia. They may have, say, hypoglycemia. They may have a CO2 retention. WBC count would be usually low. They would have a low hematocrit and increased CPK, and there will be marked low voltage ECG recorded in them. These patients should be managed in intensive care setup. They should be replaced with the intravenous levothyroxine in the bolus of 500 microgram. First bolus followed by 50 to 100 microgram, either through intravenous, or maybe if they regain some consciousness or if the NG tube has been passed, it should be replaced with nasogastric tube. Majority of them have infection as a precipitating cause, so they are started on antibiotic. They may have a marked respiratory depression and CO2 retention, so they may have to be ventilated or put on ventilator after insertion of a endotracheal tube. This increased in say metabolism caused by a rapid replacement thyroxine would result in an increased demand for hydrocortisone as well. And if you do not replace hydrocortisone, they would become a relative say hypercortisolism, or maybe relative Addisonian. So all of them should have an in addition to levothyroxine, replacement of hydrocortisone intravenously as well. They should be warmed through warm blankets, and they should be carefully monitored for their volume replacement, since a rapid crystallite replacement may lead on to worsening of their already existing hyponatremia. And if they are hypoglycemic, the sugar has to be administered, and if they are hyponatremic, then again they may have to be replaced with hypertonic saline, or sometime with the avoiding the 5% dextrose water being replaced. Some of these patients, if remain untreated for quite some time, they go on to from a depression to psychosis to madness. So this is usually manifested as delirious state with auditory hallucinations and sometimes paranoid delusions. And this take on the form of psychotic depression or pure psychosis. There is no cognitive impairment. Treatment is thyroxine. Some of the individuals may have a total T3 being reduced, free T3 is reduced, but total T4 is not reduced. But free T4 is normal and TSH normal, and clinically they are euthyroid. This state is called as sick euthyroid state, where the intercurrent or concurrent illness has led on to decreased conversion of from T4 to T3, or a decreased peripheral availability. So this is not need to be treated. All patients, particularly women above 60, should be screened for a possible hypothyroidism, as the incidence is quite high. All those women who have a family history of thyroid disease should be repeatedly or screened for possible hypothyroidism through estimation of the TSH level. Those who have previously shown some thyroid dysfunction either during pregnancy or postpartum or peripartum period should be screened for that. Those who have symptoms suggestive of hypothyroidism or hyperthyroidism or abnormal thyroid gland on examination at any stage of their life should be screened for. Type 1 diabetics, since it's an autoimmune type of illness, should also be screened for pre-existing or coexisting hypothyroidism, and all those with history of autoimmune disorders should also be screened for that. This is an abandoned British era railway track in near Pind Dadan Khan, where used to be a very regular railway service from this Lahore and other areas to those remote areas, but this has been abandoned and मुद्दत से कोई आया ना गया, वीरान पड़ी है घर की फिजा. Thank you for your attention, and in the next lecture we'll be starting on with the adrenal disorders. Thank you.